toric IOLs in special situations where you can do them, where you cannot do them, and where you should be aware of the challenges involved. So the specific case scenarios that I'll be discussing are eyes that are post-refractive surgery, those with corneal ectasia, and eyes that are post-keratoplasty. So let's start with post-refractive surgery eyes. So essentially the challenges that you have in these eyes pre-operatively are to get the keratometry right and subsequently the IOL power calculation. Then you have the next challenge of choosing the intraocular lens you're going to be implanting. The limitations that your keratometers, placido topographers, and some of the optical biometers have here is that they're essentially measuring only your anterior corneal curvature. They're not measuring the posterior corneal curvature. They are assuming a ratio between the two, and they're also blind to the exact center of the cornea, and they're also extrapolating that information. So all of this is fine when you're looking at virgin eyes or healthy corneas, but that's not valid when you had an eye that has undergone refractive surgery. So this is where I find Scheimpflug tomography to be extremely useful in these set of eyes. The map that I like to use is the Pentacam EKR map, and I'll just discuss this map because I'll be showing this map in the other case scenarios as well. So this essentially calculates the equivalent K reading values of the cornea in two steps in such a way that you can feed these keratometry values directly into any IOL formula that is using a refractive index of 1.3375. So let's look at this eye here. This is an eye that has undergone refractive surgery. You can see the equivalent K readings in different zones, and this is centered at the pupil. You see this histogram here. You can see there's a single uniform peak there. This is an indication that this is quite a regular cornea. When you look at the K values also across different zones, you can see that these are quite consistent across the different zones, and that again indicates that this is quite a healthy cornea even though this individual has undergone refractive surgery in the past. So here I would not hesitate to use even a multifocal IOL. There is, in this particular case, no need for a toric IOL because as you can see there is not much of astigmatism. When you look at this cornea on the other hand, you see that there is astigmatism, there is cylinder. You see that this histogram is widely spread out, which you do expect in a case of astigmatism, but you see that the standard deviation here is quite low. Now this is indicating that this is a regular cornea which has astigmatism, and therefore you can consider a toric IOL here. And if the individual wants a multifocal, you can still go for that as well, because you can see that this is a healthy cornea with astigmatism. It's not an unhealthy cornea with irregular astigmatism. On the other hand, when you see a case like this, you can see the histogram is very widely spread out. You can see the keratometry values here are all over the place, and the standard deviation is extremely high. So an individual like this, you should not be choosing a toric IOL, and absolutely no multifocal IOL in this case. So this is how I would go about choosing which individual I can go for a toric IOL. And now when you're feeding these values, you can feed it directly into the ASCRS online calculator. If you're planning a toric, like in the case that I showed you, these values of the keratometry values can be fed directly into the Barrett True K toric calculator, which is meant for these eyes. So moving on to individuals that have corneal ectasia. So again, IOL power calculations, not just the toricity, but even the IOL power calculations by themselves in keratoconus are challenging. And the reasons are that this is essentially irregular astigmatism. You do have difficulties in estimating the effective lens position as well here. And usually you end up with a hyperopic refractive error post-operatively. The cone location in case of keratoconus can also influence outcomes. So when you're choosing your IOL power, particularly toric IOLs in keratoconus, what is important is that you should be aware that this is just an astigmatism debulking procedure. You are not trying to eliminate the astigmatism. And a lot of keratoconus patients are happy with RGPs or scleral lenses. So those are patients that you should not be considering toric IOLs in. Always under-promise in these patients and counsel about the possibility of a refractive surprise, and tell them that you're just trying to reduce the astigmatism here, not eliminate it. Now, which is the right formula for choosing the IOL power in keratoconus? So, literature has shown that it is essentially the best formulas for IOL power calculation with the most accurate outcomes are the Barrett True K formula, the Kane formula for keratoconus, and the SRK-T formula. Now, my preferred formulas again are Barrett True-K Toric calculator when you're choosing a Toric IOL. Here you have the option of selecting that the individual has keratoconus, and the Kane formula for keratoconus also works very well when you're considering a Toric IOL. So the considerations of choosing whether to use a Toric IOL or not in keratoconus, my decision making is quite similar to what this literature, this review article in Current Opinion points out. So the most important thing, of course, is that the keratoconus has to be stable. If it's not stable, definitely no Toric IOL. Then you look at how severe the keratoconus is. If it's mild to moderate keratoconus, which means that the keratometry is less than 55 diopters, you can consider a Toric IOL because that has reasonable outcomes. Whereas if it's very severe keratoconus, the keratometry values are more than 55 diopters, then absolutely do not place a Toric IOL. And when you're, in terms of your IOL power selection, if it's keratometry values less than 48 diopters, you can go for plano. But again, as the keratoconus is more severe, you should be targeting more myopia in these patients because you expect a hyperopic surprise to a certain extent. There is another additional consideration is centered cones in keratoconus usually tend to do better. So if you have an extremely decentered cone such as this one, it would be a good idea to regularize the cornea either by placing an intracorneal ring or by doing a topo-guided PRK prior to your cataract surgery, and then after a few months doing your refractive, your IOL power calculation, and then going in for a Toric IOL. So moving on to eyes that have undergone keratoplasty. So the prerequisites here are suture removal should have been done. The refraction should have been stable. The visual acuity prior to the development of cataract should have been at least reasonable. Otherwise, there is no point of considering a Toric IOL in these cases. Also, the astigmatism should be regular to the extent possible. The outcomes of cataract surgery with Toric IOLs in keratoplasty are reasonably good. Of course, they are going to be lower than virgin eyes, and that's been documented as well. What about when you have asymmetric or irregular astigmatism? Here, in a lot of post-keratoplasty eyes, you do have some component of irregular astigmatism. Now, similar to keratoconus here, you can use them to reduce spectacle dependence. You can use them to debulk the astigmatism, but you cannot use them to eliminate astigmatism, and that's something that you should be aware of. There are a lot of post-keratoplasty cases with huge amounts of astigmatism, and not many Toric IOLs are manufactured in that range, such as this patient who was post-DALC, and you can see has about more than 12 diopters of corneal astigmatism in these cases. You can also see that there is some amount of asymmetry. The standard deviation is quite high. You can see that the inferior ring of the bow tie has more cylinder has higher keratometry values than the superior ring. So there is asymmetry. There is some irregular astigmatism component here as well. But I did choose to go ahead with the Toric IOL after counseling the patient because I do believe that I can reduce the extent of astigmatism. If this patient was using scleral lenses or RGPs and was happy with them, I would not have considered Toric IOL. But this patient was not happy. So I decided to go for a custom Toric IOLs. So there are custom Toric IOLs available now which can be customized to up to 20 diopters of astigmatism. These are slightly bulky IOLs, need a slightly bigger incision, but they do very well. And this patient is doing extremely well with just 2 diopters of cylinder on refraction and having a visual acuity of 6.9. So you can consider this in patients that have high amounts of astigmatism, and literature also reports that these give you extremely good visual outcomes. So to summarize, good case selection and good preoperative planning is essential in achieving good outcomes in irregular corneas. The outcomes are going to be inferior to healthy corneas or virgin eyes, and that's something you and your patient should be aware of. Toric IOLs are essentially astigmatism debulking procedures where you're trying to reduce the astigmatism in cases with keratoconus and in cases with penetrating or anterior lamellar keratoplasty. And therefore, it's very important to counsel your patients well and set the right kind of expectations. Thank you.
Thank you, Dr. Tushar. I think that was quite enlightening that yes, we can have Toric IOLs in these special situations and how to deal with them. Thank you so much. That was a wonderful presentation. Any questions from the audience? For anyone of us? Sir, any comments from you, sir?
No, I think Tushar has covered it very well, and essentially the crux is that the counseling is very important part in, especially in cases like this, keratoconus and post-PK patient. I've also done many cases. So we need to counsel that we are reducing, trying to reduce down that if you have 10 cylinder, maybe you may left with 1 or 2.
Yes.
So you should not be
Yes.
fighting after the surgery that, is not been eliminated completely.
But
So-
definitely that will improve the quality of life and quality of vision.
Yes.
that-
So, but counseling is very
Yeah,
important part.
true.
Yeah. Very nicely covered.